sometimes good on paper, but it's just not in the application.
Well, thank you for navigating us.
All right, everyone's coming back together. Big thank you to Dr. Dudl, who has to go take his flight. Thank you so much. He's making a quick escape. He's leaving it all up to us now. All right, I hope that was fun with the breakout groups. Maybe I'll just represent our group. But we talked a lot about, is everyone back? It feels like there's less people. People escaped?
A couple people left.
Okay.
That always happens in breakout groups.
Well, we'll just keep moving since it's 6:30. So in our group, we talked and discussed a lot, and of course the topic is meant to go off track a little bit, but I think the biggest themes were the importance of patient engagement and getting outside of the exam room to thinking about how do we, as Dr. Kaplan mentioned, get ahead. And the things that we talked about were targeting that younger population, even younger, like what the American Diabetes Association is already doing in the YMCA's with teaching healthy behaviors and healthy cooking and things like that. And then the other point that was brought up by, where'd he go? Forgetting his name, our gentleman who works with geriatric populations, the importance of thinking about functional outcomes and not necessarily just mortality. I mean, that's measurable, but let's not forget that that's not very sexy to the younger population. It seems far away sometimes. And how can we think about functional independence or having a health span rather than a lifespan? Does that sum it up, you think, first? So yeah, we vote for Dr. Kaplan's method of thinking earlier in addition to like the standard medication packages and things like that. Okay, is there a representative from this group that wants to summarize? Okay, Melora. Because I know her.
So we similarly talked about the importance of bringing together the work in the clinic on risk factor reduction, and as well as the work in the community on doing things to reduce disparities and reduce stress and kind of start to work on some of the upstream factors. And began to strategize about in the kind of specific of Santa Clara County and Silicon Valley what that might look like.
All right.
And thank you. So we're the outside group. We're very engaged over there. So
Proud of your standing behavior.
Thank you. Yes, be active.
Beautiful.
One healthy behavior down. So our team focused on quite a few themes, and the big theme came out was about engagement. So part of you mentioned about the patient engagement part, so I won't repeat that. The other bigger part that we had is about engaging the physician, about how to prioritize this as a topic, and how to make it easy for them to engage them, to make this as a core issue to help address for their patients, came up very, very prominently. We also know health systems are heterogeneous, and their use of EHRs are also very, very different. And how do you, in a very complex system with so much variation, how do we stay focused on this as a key area to do? Came up very prominently. The other point we had is that we can't do it alone. So how do we link the strengths from community organizations, healthcare system, health plans, to construct the system that makes it easier to do and then engage it so that people are primed to say, yes, this is what I want. I want to live healthier. I'm coming in to get help is another key that came up. And one of the other points that came up is realizing that we're in a very resource-constrained world. How do we figure out how to do this together when we can assume there are not going to be new resources coming into this? And how to really meaningfully shift attention away where all the money and all the tends to be focused on the high acuity patients and really put our emphasis in the prevention part, which is really what the mission of what we need to do here to get the outcomes we want. I think that's a challenge ahead that we need to face, and I'm very excited to have this organization here to figure out ways that we can do it in our community. Anything else I missed?
No, I think it was a great job.
Thanks.
Oh, excellent. And that theme, I think, I forgot to say, came up with ours. And Hattie and I, we were just talking about it earlier, that this is really just the beginning. Like, we recognize, as you mentioned, that not everyone in this room is from Silicon Valley, and we need to get those people in the room and get the community leaders in the room and the folks that are going to help us reach outside the exam room. So I think Hattie will take names of the people and connections with those people as we start to build this group. But those were all really excellent thoughts.
I just want to say that as much as people have been very complimentary, and I appreciate that, there is no way that this work works unless each of you wrap your arm around someone and bring them forward. So, there are ways that individuals can do that. We can encourage. This is just a little simple checklist that you can go through with your patients that we've created in other communities. We can take it out to the churches, we can take it out to the temples, synagogues, faith communities, senior centers, and you can use it in the exam room just to say, these are just some real basic things that will help you to live a happier, longer life. And this is absolutely a we thing. So it's, I met Dr. Evelyn Stock at a tech ACC conference, and we bonded around coronary artery scanning and why are we not using precision medicine to be able to focus our resources on the highest risk people. And so those relationships that you have are what builds community. So it's not a Hattie thing. I'm not going to do all this work. This is a Hattie remembers that Melora used to work for Arnie, and I would speak with her by phone, but I never actually met her, I don't think, before now. So it's about becoming a community of people who are working together, linking arms to make a difference. It's not one person doing a heavy lift. The whole purpose, and Joe Sky, the Air Force guy, he would call in from Afghanistan because he knows the importance of this work and the importance of sort of having a support group of other people who care just as deeply and passionately about these issues. So it's not like Bob and Hattie can sit down and write the towards zero equation and then interview each of you and do a Delphi process and get to what are all the components. We would love to do that because that's really what makes us fun in a way. You have to engage people where they are. What excites Bob Kaplan is equations, and Hattie Hanley, we love numbers, but we also love people and community, and there are so many issues that we would have liked to have raised today, but the point is, it's coming together every month, like a drumbeat, creating a habit, knowing that we'll be together for years, making this happen. It's not like you turn a light switch and everybody comes together. Juliet and I have met over the years in different parts of the state with the American Heart Association. And Nirali, I first met when she spoke because her boss, Greg, had an accident, and then we bonded around the stroke issue because my mom died when I was just 15 of uncontrolled hypertension, stroke. And now Nirali points out, gee, in this current time, in this current place, we have this wonderful technology for finding all this undetected AFib and treating that appropriately. So it has to be parallel tracks. So there's the community building, and there's the equation building, and there's the reaching out to different parts of the community that have been non-traditional. So the fact that I have learned biofeedback from my Apple Watch is just the tip of an iceberg of what we can do now. So we're trying to put something together on AFib, and we would love your ideas on what do you most urgently need. So I heard from Poonam earlier that blood pressure and getting the standards out there is really high priority. We have been working on that for years and years and years, and we're in a flux point right now where there's just major fighting happening about what is the right answer. Is the 140/90 that we worked toward in San Diego that seemed to be pretty effective, what we should be using, or should we switch to the sprint results? So part of what we do here is we problem solve on the science and what's practical and how do you make it easy for doctors to do the right thing. And that is a subject for another day. So I would love to hear others' thoughts. Anybody wants the microphone?
I can share Hattie go about it, if that's okay. When I met Hattie, about a year and a half ago, she shared her story about her mom with me, and it was very impactful. But then also what I realized is you could be in your area of expertise wherever you lie, and you may have all the knowledge, but you miss it, because I know my mom had a stroke in June of last year, and I missed the signs, and I was arguing with an intern for 5 hours to get her an MRI. And so I think that just talks, and I was at a stroke certified center, and that really talks to,
Wow.
at that really minimal, like entry ER on the acute side, how it feeds into ambulatory. And one thing that I think when we were talking about, the positive engagement for physicians, and so when they're held accountable, but really going back to those patient and survivor stories. And so maybe one of the things at all of these meetings is having somebody from the community, from one of the partners, whether it's a community partner or whether it's from the healthcare system, actually come and talk about the work. So that way then how the work that you guys are doing as a collaborative saves lives, because it does matter. And, for those of you that know stroke, it's a long way back. And today my mom said she was a baby burrito. So, you find the humor in it, but but know that it does, and it impacts. And even though we could have all the education, it's still a systematic, and there's still work to be done. And coming from San Mateo County, the #1 county in California around health, that should say something, unfortunately.
Well, Nirali was just talking about how hard it is for physicians to actually recognize stroke. We were talking in the pre-meeting about how the chief operating officer for Intel Europe, who presented at RightCare Sacramento a couple of years ago, had actually come to Stanford. But because he looked so young and healthy, he was a triathlete. They did not suspect stroke. He did not get the scan and did not get TPA, and now he has just a really hard time functioning. So learning better protocols is something that we're really blessed in this place to be able to draw on what are the best practices. But even within a grand institution like Stanford, it's hard for a brilliant expert to be able to get all the other doctors to accept a protocol, right?
I think that's part of it, or even going a step before, like we're talking about, even, before the person has an injury, or some are preventable, some are unexpected, but for that preventable group, like what we'll get into in the future about AFib, for example, it's just getting providers, like I think, Louisa, you were saying that, what is the accountability at some of the other health systems for physicians? Not everyone is a Kaiser where it's easy to disseminate. And how do we keep physicians accountable for whether it's diagnostic or therapeutics or what might be? How do we leverage EHR, what it might be? And I think those are the things that I'm really excited to see how we can innovate here in Silicon Valley. So I'm really, again, excited to work with all of you, and I know we're running out of time, so we want people to discuss or engage.
We do have wine and food out there, if you would, and other libations, if you would like to stay and chat, and we're, happy to stay here and talk, but we also don't want to keep people longer than they're comfortable with. So we've currently scheduled these meetings at 4:30 to 6:30 with a check-in reception and a reception afterwards for half an hour. And perhaps you would like the meetings to go longer, and just give me that feedback on your evaluations. Megan and Brian will send out an evaluation under RightCare, and you can give us your thoughts. But, before we go, Dr. Ashok Krishnaswamy, you were saying you really want to focus on that end-of-life spectrum as well. Are you talking
Not
about?
specifically end of, I mean, I think that's an interest, it's generally in terms of, care of older adults. And actually, a lot of my research is trying to balance safety and benefit, and then I was listening to Dr. Kaplan in terms of, when you start thinking about hypertension management, you always end up, the lower you get, you probably end up getting better in terms of stroke reduction, but that's at a cost. It's the cost of, syncope and electrolyte abnormalities and all the stuff that are there. And so I've been very attuned to trying to think about the whole issue of balance. How do we really achieve balance in a community? Because when you look at trials, remember there are like 4 groups. You've got those people, and this is a lot of David Kent's work, is those people who are going to do really well despite what you do. Those people are going to do really bad despite what you do. And then the 2 groups in between are what you're trying to capture. Here it's a little different. You're also trying to go a little bit earlier in the spectrum, earlier in the disease spectrum, to kind of move them closer to the 2 groups that will benefit. And I think identification. So I also tend to be a number person in terms of trying to think about this, and I think part of that is, how easy is it to implement Framingham across Silicon Valley as a population? I don't know. I don't even know how that's possible, but we can do it within each of our institutions. But that's kind of how I'm thinking, and then I think the whole thing is really the whole issue of compression and morbidity that Jim Fries, I think, really started. Because isn't it really nice if we can get to 60 and 70 and we can still go dancing and marathons, or 70 and 80 and 90? And I think what I find fascinating here is really, more than anything else, the outcomes of mortality are very fine. But as a geriatric cardiologist, I think really starting to think about functional outcomes and saying, hey, when you get your 70-year-old or 80-year-old and 90-year-olds doing, the Honolulu Heart Study and marathons and what this, that's a very different population profile that we're aiming towards. And I'm thinking if you actually, I don't know if this is true, but by preventing these smaller events, the non-STEMIs, the minimal strokes, not the fatal ones, are you really compressing morbidity and pushing it out? That's kind of what I was thinking, and I can go on with that.
It's exciting.
Yes.
And the whole idea of what can be done with an exercise prescription that was first raised by Jim Salas from your Irvine Kaiser, I think is a really important one. So in this valley where people are very exercise and diet conscious, trying to help inform that discussion so that for a person who's dealt with a lot of rehab, you might be able to, we should get more defined about what that should look like. Now, the 30 minutes a day, every day here is from David Marin, the head of preventive cardiology at Stanford. And there are a lot of disagreements about that, but it's something that if we could get it in the culture from young to old, it would impact these numbers.
It's something that's with Facebook, with Apple, with Google.
Ask PBGH.
I mean, yeah, it is something that flashes up, that's a verb or something that's constant, or just,
Everybody owns
that
a
eventually
cell.
someone starts looking at it and you start to get, some of the millennials are more, but you had said earlier about, not about living so much the longer, but living for health, and I think that's an opportunity or another area to embrace the community. And I know with the AHA and the ADA and stuff going into the churches, especially they did years ago, and about knowing your blood pressure numbers or knowing your sugar levels.
They're
I think we're
promoting
seeing
these
stories.
drop-offs.
I mean, I think that's real. I mean, even as a physician, I find what's really impactful to get some of my patients who do come in with these strong beliefs that, no, that my dad died of a heart attack at age 50, and he was was on a statin, and the statin didn't work, is to come in with those powerful stories of that, you know, geriatric patient who is doing the Honolulu Marathon. And, you know, really kind of being honest about that story, how they, you know, they were on a blood pressure medicine, they did take a statin, they did, you know, these things, and really making that visible to people. And I think it goes both ways, the stories of like the folks who have, you know, trauma or tragedies early in life, and then the success stories. I mean, broadcasting that, I think, would be really impactful to folks.
Okay, I think we have to end the meeting because we're gonna keep going, but you can keep talking about it over wine. But I think ending on a patient engagement is the most important thing because that's what it's all about. Thanks, guys.